So our first speaker this afternoon is Robert Shafer. He is a professor of medicine in the Division of Infectious Disease at Stanford University. This is a man famous to all of us. In 2000, he created the standard HIV drug resistance database, and I think probably everyone on this line has used that database, and if not, you better use it tomorrow. So Robert is going to address the issues of 2 drug regimens and the implications for resistance. Thank you.
Hello, my name is Dr. Robert Shafer, and it's a privilege to be able to speak to you today about the implications of drug resistance for the HIV pandemic. These are my disclosures. I've organized this talk into 2 parts. The first is on pre-treatment drug resistance, and the second is on acquired drug resistance. The first part will focus on the topics on this slide, explaining the difference between pre-treatment drug resistance, or PDR, and transmitted drug resistance, or TDR. Reviewing data on the prevalence of PDR, on the clinical implications of PDR, and on the prevalence of transmitted integrase inhibitor resistance. During both parts of the talk, I will present data on HIV drug resistance from both low and middle income countries and upper income countries. TDR is the prevalence of drug resistance in ARV naive persons. TDR prevalence determines the risk of a person becoming primarily infected with the drug resistant strain. It is useful to identify hotspots of transmission of drug resistant viruses. PDR includes resistance in ARV naive persons as well as ARV experienced persons initiating or reinitiating first-line ART, including women who received ART to prevent mother-to-child transmission, persons in whom ART was interrupted, and persons who received pre-exposure prophylaxis. PDR reflects the overall burden of HIVDR in populations starting or restarting ART, and is valuable to support public health decision-making in the absence of HIV drug resistance testing. This figure shows data from a 2018 systematic review showing the rising prevalence of NNRTI-associated PDR in 5 regions: Southern Africa, West and Central Africa, Eastern Africa, Asia, and Latin America and the Caribbean. And in 3 of these regions, Southern Africa, Eastern Africa, and Latin America and the Caribbean, rates of NNRTI-associated PDR reached 10% by 2015. This figure shows data from the 2019 WHO HIV drug resistance report. The top figure shows data from 12 of 18 surveys in which NNRTI-associated PDR was above 10%, shown here. And these were particularly in Southern and Eastern African countries as well as Caribbean countries. The figure beneath that shows that, in fact, a large proportion of the patients with PDR were those who were restarting therapy, shown in red, rather than those who had been completely ART naive at the start of therapy, shown in black. This figure shows the most common drug resistance mutations observed in PDR studies. Among the NRTI-associated mutations, the most common is M184V, which is associated with high-level resistance to 3TC and FTC. Thymidine analog mutations, such as those at 41, 215, 219, were also quite common. However, these are not considered to be very relevant for a first-line tenofovir-containing regimen because multiple thymidine analog mutations are required to reduce tenofovir susceptibility, and because the most important of the thymidine analog mutations, T215Y and F, are actually transmitted very uncommonly. Most of the transmitted 215 mutations are referred to as revertants, and they're phenotypically neutral. The classic tenofovir resistance mutation, K65R, occurs in about 2% of those viruses that were had transmitted drug resistance. And even though these viruses cause only twofold reduced tenofovir susceptibility, that level of reduced susceptibility is considered clinically relevant. These are the most common NNRTI resistance mutations that have been observed in during surveillance studies. There are major differences in the significance of TDR in low, middle income, and upper income countries. And the main difference is that in upper income countries, genotypic resistance testing is done prior to therapy so that therapy can be tailored, and because integrase inhibitors have really replaced NNRTIs in most first-line regimens. TDR strains in upper income countries also often reflect ongoing transmission in ART-naive persons. As a result, these strains have fewer DRMs, and those that are present are often associated with drugs that are not being used any longer. And among those strains with TDR, these are the rates of the most important drug resistance mutations, and they're somewhat lower than those shown in the previous slide. So what is the clinical significance of PDR in persons beginning at tenofovir-containing NNRTI regimen? Well, the range in various studies has been between having a minimal increased risk of virological failure to having a 2 to 3-fold increased risk of virological failure. And the risk is highest in those in persons reinitiating therapy. In other words, those who were somewhat ART experienced, than in those who are completely ART naive. And the risk is definitely higher in those with dual NRTI and NNRTI resistance before starting therapy. And of course, the risk is expected to be quite low in those persons who start a dolutegravir-containing regimen rather than a first-line NNRTI-containing regimen. And I've shown here 6 of the most recent and most relevant references that speak to the increased risk of resistance in those with PDR. So we don't have there's been no standard approach yet to determining the prevalence of integrase inhibitor transmitted drug resistance. So last year we performed a meta-analysis of integrase sequences from about 17,000 integrase inhibitor naive individuals and from about 2,500 integrase inhibitor treated individuals, and identified 24 common non-polymorphic integrase inhibitor resistance mutations at 12 positions, which I've listed here. We also identified several polymorphic resistance mutations, which I've also listed here. These mutations do contribute to drug resistance, but only when they occur in combination with the non-polymorphic mutations. This year, we did a systematic review of published studies of integrase sequences in ART-naive persons and found that the frequency of integrase inhibitor resistance in this population is quite low, below 1%. And in fact, the largest of the studies was recently presented at CRY this year by the CDC. They looked at about 3,000, they looked at samples from about 3,000 persons and found that the proportion with transmitted integrase inhibitor resistance was 0.8%. So I'll move on to the second part of this talk, which pertains to acquired drug resistance. And I'll review prevalence of the prevalence of acquired drug resistance and the patterns of resistance mutations that are observed, the implications of acquired drug resistance on first-line therapy for second-line therapy, and final slides on PI resistance in low and middle-income countries and third-line therapy in low and middle-income countries. The incidence of virological failure on a first-line NRTI and NNRTI-containing regimen is estimated to be about 15% to 40% over 5 years. And about 70% to 90% of persons with virological failure in such a regimen will have developed NRTI and/or NNRTI resistance. An estimated 1 to 2 million persons have developed acquired drug resistance on a first-line NRTI and NNRTI containing regimen. Data are not yet available on the incidence of virological failure and acquired drug resistance in persons receiving a first-line dolutegravir containing regimen. This slide shows the most common mutations observed in recent WHO surveys of acquired drug resistance. The most common mutations are M184V and I, observed in more than 50% of patients, and a lower proportion develop the classical tenofovir resistance mutations, K65R, in about 30% of persons. This is data that we published a few years ago showing the patterns of drug resistance mutations in patients failing a first-line tenofovir-containing regimen. And what it shows is that about half of the patients will actually have full susceptibility to tenofovir and AZT because they either have no drug resistance mutations or just M184V and I. But the remaining patients will have some evidence of reduced of tenofovir susceptibility. In other words, they've developed a mutation associated with tenofovir resistance. In those patients, AZT is expected to be fully active because actually M184V and I, as well as all of the tenofovir resistance mutations, increase AZT susceptibility. However, surprisingly, tenofovir also retains a lot of activity despite the prevalence of tenofovir resistance mutations. And in fact, several of the viruses have a fold resistance less than 1 because of the effects of M184V and I, which lead to increased tenofovir susceptibility. So this slide shows the WHO recommendations for second-line therapy, and I'm just going to focus on the scenario that we've been discussing. Persons with virological failure on a dual NRTI efavirenz-containing regimen. The NRTI is usually, one of them usually is tenofovir, who are recommended to be switched to a regimen consisting of 2 NRTIs and dolutegravir. And the text of the guidelines writes that an optimized NRTI backbone should be used, such as AZT in those who received tenofovir, as well as tenofovir in those who had previously received AZT. But this recommendation is currently still being debated because tenofovir is actually much better tolerated than AZT. And as I showed on the previous slide, even in persons with virological failure on a tenofovir-containing regimen, there is rarely high-level tenofovir resistance. In addition, with the introduction of TAF, which is 4 to 5 times more potent than tenofovir, I'm sure that these guidelines will be revisited. This is some data from an upper-income country. This is from California, and it's data that we've submitted for publication and which I expect will be published quite soon. It shows data from about 2,300 persons receiving first-line therapy between 2010 and 2017. And during this 8-year period, 95% of persons received 1 of 6 companion antiretrovirals, including the NNRTIs efavirenz and rilpivirine, the integrase inhibitors, elvitegravir, raltegravir, and dolutegravir, and the protease inhibitor darunavir. The incidence of virological failure was 3.0 per 100 person years, and the incidence of HIV drug resistance was 0.8 per 100 person years, indicating that fewer than 1/3 of persons with virological failure developed acquired drug resistance. The high rate of virological failure without resistance reflects the fact that most of the virological failures in our cohort and also in many upper income country settings results from persons discontinuing therapy. The table below the figure shows the types of mutations observed during virological failure. And so among the 62 patients with virological failure and drug resistance, those who developed who were receiving an NNRTI tended to develop both an NNRTI resistance mutation and an NRTI resistance mutation. Those who received integrase, an integrase inhibitor, and this was primarily elbapygravir and raltegravir, the mutations observed were integrase inhibitor resistance mutations and NRTI resistance mutations. But among those who developed who received a PI, the only mutation to develop was M184VI. Protease inhibitor resistance mutations didn't develop at all during first-line therapy in this cohort. So now I'll turn to a later stage of therapy, and studies from sub-Saharan Africa have shown success rate of about 65% with second-line therapy at 1 to 2 years, and from South and Southeast Asia, about 75% at 1 to 2 years. Resistance to protease inhibitors develops at a much slower rate than resistance to NRTIs and NNRTIs. However, this figure shows that by 2 to 3 years, about 25% of persons receiving a second-line lopinavir-containing regimen will have developed one or more PI resistance mutations. We don't have similar data yet for atazanavir, which is also recommended for second-line therapy. We and others have reported, however, that even after prolonged virological failure on a lopinavir-containing regimen, high-level darunavir resistance is extremely rare. Rather, about 40% of patients at the time of virological failure will have developed, well, it's about 45% who have virological failure and lopinavir resistance will have some degree of cross-resistance to darunavir, but it's usually low-level cross-resistance. Nonetheless, third-line antiretroviral therapy is becoming an increasing requirement in low and middle-income countries. And several countries have set up programs to offer such therapy. And in these countries, they typically attempt to do genotypic resistance testing because therapy often needs to be individualized in such patients. And the regimen usually consists of a boosted darunavir with or without dolutegravir, with or without 2 nucleoside RT inhibitors, and with or without an NNRTI such as etravirine. Raltegravir used to be used in these third-line programs, but dolutegravir has taken its place because of its higher genetic barrier to resistance. Of note, dolutegravir should not be used with etravirine unless it is also used with a boosted protease inhibitor because of a pharmacokinetic interaction. South Africa, which has the longest standing third-line program, has reported an 85% virologic suppression rate at week 48, and this was even prior to the substitution of dolutegravir for raltegravir, and the reference for this program is shown at the bottom here. In conclusion, pretreatment drug resistance will remain an obstacle to successful therapy in low and middle income countries unless more persons have access to first-line dolutegravir-containing regimens, or at least to genotypic resistance testing. Transmitted integrase inhibitor resistance has remained very low in all countries, including those countries with the greatest use of integrase inhibitors. In low and middle income countries, both NRTI and NNRTI resistance mutations occur in a high proportion of viruses from persons with virological failure on a first-line NRTI, NNRTI containing regimen. Second-line therapy with a dolutegravir containing regimen is recommended along with an NRTI switch from tenofovir to AZT or vice versa. However, the optimal NRTI combination in this setting is still being considered. In low and middle income countries, an increasing number of treated persons are developing virological failure and PI resistance on second-line lopinavir containing regimens. Third-line therapy in this setting is often individualized based on genotype and will usually contain darunavir with or without dolutegravir, with or without 2 NRTIs, and with or without an NNRTI. So I'd like to finalize this talk by acknowledging my research group at Stanford University and the NIH, which has provided funding for our HIV drug resistance database, as well as for most of the other projects we have conducted during the last few years. Thank you very much.
Well, thank you, Robert, for very much outlining to us the considerations that we have to make in choosing antiretroviral therapy, both for transmitted resistance as well as acquired resistance. And I just will ask one brief question before we go on. And my question to you is now that we're considering the 2-line combination of dolutegravir plus 3TC, would this be a regimen that you would recommend in low and middle income countries given the high prevalence of 3TC resistance?
I'm having trouble starting my video, but let's see, let me try again. Oh, there it goes. You know, I think the studies, enough studies haven't been done there. So I think it might be premature to use a 2-drug regimen, especially, it might be fine to start off with the 2-drug regimen in patients who have genotypic resistance testing prior to starting therapy. But in those who have not had genotypic resistance testing, or in those, for instance, who are stably virologically suppressed on a regimen where we feel very comfortable using a 2-drug regimen here, I think it would be too early to do that in a low and middle income country right now.
Okay, well, I think we'll save the rest of the questions for you for the round table discussion. And I thank you again, and we will move to our next speaker. Our next speaker is a friend and colleague, Dr. Marta Boffito. As many of you know, she is a consultant physician and the clinical research lead, as well as the HIV service lead at the Chelsea and Westminster Hospital in the UK. Marta is among one of the few pharmacologists who have an incredible knowledge base with respect to HIV, its treatment, and particularly drug interactions. And Marta today is going to address the issue of the implications of reduced drug regimens for sanctuary sites and drug interactions. Marta, welcome.
Hi, my name is Marta Boffito. I work in London at Chelsea Westminster Hospital, and I'm going to talk about implications for sanctuary sites and drug interactions in the context of administration of reduced drug regimens. Next slide. This is my conflicts of interest. Next slide. What do we mean for sanctuary sites? These are the anatomical and cellular HIV replication reservoirs, and they are all over the human body. They're in the central nervous system, so they are the cerebrospinal fluid and the brains that are actually 2 different compartments within the central nervous system. They are lymph nodes which are distributed all over the human body, or they are cellular areas in the gastrointestinal tract or in the genital tract. Next. So we actually can have a look at reduced drug regimens from the past, the present, and a bit of the future, and see what happens in sanctuary sites. Next. For what concerns reduced drug regimens in the past, we already know that neurocognitive function and neuroimaging markers in people living with HIV with an undetectable viral load do not differ if people are on darunavir-ritonavir monotherapy versus being on 3 antiretroviral drugs. Next. But what about the presence? So next. Today, when we talk about reduced drug regimens, we talk about unboosted integrase inhibitors together with the reverse transcriptase inhibitors, either in nucleoside reverse transcriptase inhibitors like lamivudine or a non-nucleoside reverse transcriptase inhibitors like rilpivirine. This slide shows the data from the Gemini study, the virological response at week 96 in antiretroviral naive patients who started dolutegravir, lamivudine, or a 3-drug regimen, and showed that the 2-drug regimen is non-inferior to the 3-drug regimens. So what happens in sanctuary sites in people on 2-drug regimens with dolutegravir and lamivudine? Next. We actually have data about the genital tract. If we look at the sub-study in the genital tract from 2 different studies, ACTG 5353 and ASPIRE. ACTG 5353 is a single-arm pilot phase 2 study that enrolled antiretroviral naive patients who started dolutegravir lamivudine, while ASPIRE is a switch study in patients with an undetectable viral load that either continue the 3-drug regimen or switch to dolutegravir lamivudine. So the sub-studies of this larger clinical trials looked at viral load in the genital tract and showed that very few people had a detectable viral load in seminal plasma. This is for men. Women enrolled in the study all had an undetectable viral load in the genital tract. The people who had a detectable viral load in the seminal plasma had viral loads below 500 copies. And these results do not really differ from what it was shown in people on 3-drug regimens in the literature who showed to have a detectable genital HIV RNA in approximately 2 to 20% of cases. So in conclusion, we can say that this result suggests that dolutegravir lamivudine confers a similar transmission prevention benefits as triple therapy. And importantly, this was also recently confirmed by the Lamido sub-study that looked at genital tract viral loads in people on dolutegravir and lamivudine, and again just showed that only 3 people out of 104 had detectable viral load in the genital tract, and these viral loads were all below the 500 copies an hour. Next. So what about the central nervous system? So we know that dolutegravir concentrations are measurable in the CSF. We know very little about the brain, but we know also that the HIV RNA reductions in the CSF are similar to those observed in plasma. And this is really important because drug concentrations are very difficult to measure and to interpret in sanctuary sites. However, if we have good results, good pharmacodynamic results on what happens to the viral load, we can interpret what happens in sanctuaries, HIV replication sanctuaries. We know that lamivudine concentrations are measurable and stable over time in the CSF. And This is similar for rilpivirine, which is a potential other partner for dolutegravir for 2-drug regimens, as rilpivirine has been measured both in the genital tract and in the CSF. Next. So what about drug-drug interactions? Now, we hear frequently that less drugs lead to less drug-drug interactions. This is true, but obviously it depends on the components of the antiretroviral regimen. So when we select NRTIs or unboosted integrase inhibitors to partner in 2-drug regimens, for example, if we select drugs characterized by a low potential for drug-drug interactions, we can confirm that less drugs means less drug-drug interactions. Next slide. Drug-drug interactions happen between antiretrovirals and co-medications, and the antiretroviral drugs can either be the perpetrator of a drug-drug interactions or the victim of a drug-drug interaction. Next. So if we think about 2-drug regimens containing dolutegravir and lamivudine or dolutegravir and rilpivirine, we need to be knowledgeable about drug-drug interactions involving dolutegravir. So in terms of dolutegravir being the perpetrator of drug-drug interactions, we have to remember only one interaction, which is between dolutegravir and metformin at the level of the kidney. And this is because dolutegravir is an inhibitor of the transmembrane transporters called OCT2 at the level of the renal cells in the proximal tubule. So dolutegravir inhibits the activity of CT2 and leads to an increase in metformin plasma concentrations. Metformin doses when co-administered with dolutegravir needs to be reviewed, especially in the presence of renal insufficiency and kidney failure. However, we have extensive clinical experience nowadays of co-administering metformin with dolutegravir with very limited negative outcomes. Next. Importantly, lamivudine is not a victim for drug-drug interactions, and dolutegravir is a victim of very few drug-drug interactions. We need to remember to double dolutegravir dose to 50 milligrams twice a day in the presence of strong inducers of dolutegravir metabolism like rifampicin and carbamazepine. And also we need to remember about the importance of separating the administration of magnesium aluminum containing antacids with integrase inhibitors. So in the case of dolutegravir, we need to make sure that dolutegravir containing combinations are even given 2 hours before or 6 hours after magnesium aluminum containing antacids to avoid drug-drug interactions at the level of absorption. Next. For concerns rilpivirine, it is a victim of drug-drug interactions with moderate and strong cytochrome P450 Cyp3A4 inducers, and also interacts with proton pump inhibitors. And I would like to remind everybody that you can find all of these informations in the HIVDruginteractions.org website from the University of Liverpool. Next. So what about the future? I think that there are new 2-drug regimens that are going to become available in clinical practice. And this can be true for drugs that are already approved for the treatment of HIV or that are experimental. The drugs that are going to be partnered in 2-drug regimens are going to be characterized by a low potential for drug-drug interactions. So this is good news because it will make the management of antiretroviral therapy easier. I'm talking about potential combinations like doravirine and dolutegravir, or doravirine and islatravir, which are currently studied in phase 3B clinical trials, and many more, like the combination between the injectable cabotegravir and rilpivirine, and I'm sure others that are being studied. What we need to keep an eye on is data on the achievement and maintenance of the undetectable viral load in sanctuaries. But I think we've learned a lot with the data on dolutegravir and lamivudine. So we're quite knowledgeable about what we want to study and what we want to achieve in order to be reassured that in the context of two drug regimens, what it is achieved is not different than what happens for three drug regimens. So in conclusion, next slide, drug concentrations in sanctuaries are difficult to measure or interpret, but we can assess pharmacodynamic data, and these are key, and they involve the measurement of viral load in sanctuaries, or they could be larger public health studies like the partner studies, and these are again key in what kind of information help us understand that HIV replication in sanctuaries is not clinically relevant. Drug-drug interactions potential depends on the antiretroviral combination components, so less drugs have a lower potential for drug-drug interactions, especially if these drugs are characterized for a low potential for drug-drug interactions. And I think we're learning a lot about two drug regimens, and we now know what to look for in the context of the sanctuary sites and drug-drug interactions. Thank you very much for your attention.
Thanks very much, Marta, for a very clear presentation. And I think, as you pointed out, for years, we've always worried that despite suppression of viral load in the plasma, are there going to be viruses in the sanctuaries that may be the source of viral replication, the development of resistance? So I think you provided us some reassuring data that it seems to be the same with the two drug regimens or the three. I think one of the burning questions is, you know, what you did present was cross-sectional data. In two drugs, we don't see it, or we see it the same amount as three drugs. Are you aware of any data where people have been on three drugs, then dropped one drug, and then they measure the sanctuary before and after? Are you aware of any data such as that?
Sorry, so I think it's a very good point, and at the moment there are no data on that, but it would be the ideal way of studying it, because you look at the intra-individual comparison of what happens before and after you remove a drug. So it can be done as a sub-study in switch studies from 3 to 2 drugs, but I'm not aware of any data. And again, that would be a perfect study design to really answer the question.
Okay, and I think once again, Marta reminds us that even though there's fewer drugs, it doesn't mean that drug interactions may not happen. And I am fortunate to have someone like Marta that I'm able to turn to. But I have these questions all the time about these drug interactions. And as she pointed out, that website is beautiful if you're not sure about some potential drug interactions. We also have one here that our pharmacist, Alice Singh, has done that you can get on our website as well. And those are really helpful if you are considering introducing a new drug into a patient's regimen to understand whether or not there may be an important drug interaction. So Marta will hold any other questions until the round table. And again, I would like to invite the audience to make sure that you put your questions in the chat line so that we will be able to address them during the round table session. Thanks.
And it'll be my pleasure to introduce our next speaker, who is Sharon. Sharon Walmsley is Professor of Medicine at the University of Toronto and a Senior Scientist at the Toronto General Research Institute. She's also the Assistant Director of the HIV Clinic at Toronto General Hospital and co-director of the Clinical Management Core of the Canadian HIV Trials Network. Dr. Walmsley was named a member of the Order of Canada, the country's highest civilian honor, a very well-deserved award, as any of us who have worked with her or those who have been treated by her will testify. Sharon has been at the forefront of HIV treatment and research for many years, caring for patients, teaching young doctors, and directing pioneering and original clinical trials. The optimal care of women living with HIV has always been a topic very close to her heart, and she is without question a leading world's expert on the topic. Today we have the pleasure of Sharon speaking to us on reduced drug regimens and their implications for women's health. Sharon, the floor is yours.
G'day, it's Sharon Walmsley talking to you from my office in Toronto, where we continue to be in lockdown. Today, I'm going to talk to you about these reduced drug regimes and what the implications are for women's health. So whenever we think about antiretroviral therapy in women, there are some considerations that we need to take into thought. One, will there be differences in the pharmacokinetics of the drug, largely because women often weigh less than men, and there is often a difference in terms of the distribution of body fat and muscle. As we've learned from many antiretrovirals in the past, there may be some unique toxicities in women, such as the rash with nevirapine, the gastrointestinal symptoms with the protease inhibitors, and now weight gain with integrase inhibitors. And then, of course, for women, we always need to think about the safety and efficacy of the drug in pregnancy, if a woman is planning pregnancy, or drug interactions if they happen to be on oral contraceptives or hormone replacement. So if we look at the two drug regimens, is the efficacy in women as good as in men? And once again, for all of our randomized controlled trials, which has been the case for many years, the proportion of women enrolled in these trials continues to be a challenge, making it very difficult to extrapolate the findings in this gender. So you can see in Gemini, we had 14%, Sword 22%, Tango only 18%, but there was a bigger attempt in the Atlas and Flare studies to get more women involved. But they're still only at 25% and therefore not enough power to confirm efficacy in women. And then as we get on to the injectables and the implantables, the big question is, are these going to be acceptable for women? Will they have more problems with injection site reactions? Will these drugs be able to be combined with contraceptives or preventions against STIs? Where is going to be the best place for delivery of these for women? And then how long will they have to be taken away or removed before a pregnancy? On the other hand, the postpartum period may be an excellent time to study these drugs in women where adherence and postpartum depression can complicate their therapy. So what is the data? What is the data on the efficacy of the 2DR in women? So if we start first with the Gemini studies, which was the combination of dolutegravir and lamivudine versus the combination of dolutegravir, lamivudine, and tenofovir, you can see here, if we look by gender, the efficacy in women was as good as that in men. Again, we have these confidence bars, which are largely in women than in men because of the lower numbers, but it does look like the efficacy was similar. Moving now to the Tango study, which was a study in which people who were suppressed on antiretroviral therapy either continued that drug or switched to dolutegravir and 3TC. Again, if we look in gender here, as you can see, the number of women is small relative to men, but the efficacy of the two drugs appeared to be similar. Moving now to SWORD. SWORD was a switch study in which people who were controlled on antiretroviral therapy with no prior resistance were switched to dolutegravir and rilpivirine. And again, when we look at gender, there does not seem to be any difference in terms of the efficacy of the two treatment regimens. If we move to Atlas and Flare, so these were the two studies of cabotegravir together with long-acting rilpivirine. For Flare, it was in naive patients. For Atlas, it was in switch patients. Again, the women are here, the men are here, and as you can see, comparing standard of therapy here to this combination of the long-acting rilpivirine, women did as well as men, with 92.6% of women having virologic success with the long-acting regimens. So it would appear that the efficacy of the 2D regimens are the same. What about the adverse events? Are they any different? So again, we'll go through these studies. If we look at SWORD, looking at the number of adverse events that led to withdrawal, you can see that most women tolerated this well, with only 5 out of 120 women in the dolutegravir and rilpivirine arm having to stop because of an adverse event. If we move to Atlas and Flare, and again, these are pooled observations looking at drug-related serious adverse events. You can see that they were very small in both genders and that there were no drug-related serious adverse events or death occurring in women in any of these studies. If we look at discontinuation, and obviously with an injectable type of therapy, the main reason for stopping would be because of pain. And if we look at the incidence of pain in the injectable therapy in women, very similar to that with men, and again with only 2 women having to stop the drug because of painful injections. But of course, now we're worried because most of our 2 drug regimens do contain an integrase inhibitor, and we now have had these reports of weight gain with integrase inhibitors. There's not a lot of unanswered questions. Is it truly the integrase, and is one of the integrase inhibitors more significant than the other? Is TAF important? And if so, what are the implications for the 2D regimens because they don't have TAF or they don't have tenofovir? Or is it really a drug interaction issue and not the integrase alone? And then lastly, is there a genetic, racial, or gender component? And if there is, can we identify the risk factors? Can we identify who's going to get this? And then obviously an important clinical question is whether it's reversible or not. So where this evidence came was from the ADVANCE study, which was a randomized controlled clinical trial in which one group received dolutegravir with TAF and FTC, one group received dolutegravir with tenofovir and FTC, and then the third group received efavirenz with tenofovir and FTC. This is looking at the proportion of people who had more than 10% increase in weight, and this graphed the people with treatment-emergent obesity, which seemed to be highest in this group of individuals who received dolutegravir with FTC and TAF, leading to the suggestion that perhaps there is a combination effect here or an interaction approach. But the big concern is that this weight gain was certainly observed to be higher for women than it was with men, regardless of the component. And so I think this has led many individuals to take pause about the role of the integrase inhibitor together with TAF in our HIV-infected women. And if we compare across studies, and again, you have to be very careful when you compare across studies because they have different genetic components, they have different gender components. But as you can see, the weight gain in these studies across the board seems to be highest in this advanced trial in women primarily who received dolutegravir with FTC and TAF. And so we're left with this question again, is it the drug? Is it the gender? Is it the genetics? Again, what are the reasons behind this? Another consideration for women with the injectable 2 drug regimens is, are there any unique PK considerations? And so this was a study done from Atlas and Flare. It was looking at drug levels by gender or one's sex at birth and also at baseline BMI. Overall, the pharmacokinetics were similar, but as you can see, both in women and in those with higher BMIs, there was this lower trough levels, particularly early in therapy, that related to the slower absorption of the drug. And this may be related to gender and body fat content. It was not thought to be clinically relevant and was not associated with any clinically significant outcomes. Similarly, in the studies that have been done with cabotegravir for prevention, again, there seems to be a longer PK tail in women relative to men, which may have some implications for the drug being in their system for a much longer period of time after the drug has been discontinued. What about the injectables? Do women like these, or are they more concerned about the discomfort associated with them? And as part of both the Atlas and FLAIR study, the participants completed a number of these quality of life scores and satisfaction scores. And in general, there were, as I alluded to before, there were very few women who had to stop the drug because of adverse events. And the women, for the most part, had very high satisfaction with the injectable. And the reasons for that is because the regimens were flexible, convenient, and most of the women were willing to continue taking these drugs. Of course, the caveat, of course, as we've all alluded to in these trials, is people who are going to participate in studies of injectable drugs are going to be people who are going to more likely be satisfied with these treatments, and people who might be afraid of taking an injectable drug would never have been enrolled in the first place. Another consideration for these regimens is what about drug-drug interactions? And we know that these are very important for women either on the birth control pill or women at later stages of life who may be on hormonal contraception. Of course, we worry about inducers because inducers of Cyp3A4 may decrease the activity of either the oral contraceptive or the hormone replacement therapy, nevirapine being the most significant inducer. And as you can see, most of the agents that are used in 2D therapy are not strong inducers. Rilpivirine is considered to be a relatively weak inducer. The other side of the coin is whether or not the antiretroviral drugs will inhibit cytochrome P450. So certainly in some of the 2D regimens, which include a protease inhibitor plus 3TC, there could be a problem of the protease inhibitor influencing the Cyp3A4. 3TC with dolutegravir, no concerns, either for induction or for inhibition. So this would be a safe regime to use with either an oral contraceptive or hormone replacement therapy. And as I alluded to before, with rilpivirine being a minimal inducer, again, there is minimal concern about these 2DR components interfering with that combination therapy. What about women who are thinking about getting pregnant? Should 2DR be used here? And I think, again, one of the major unanswered questions is what is most important in the prevention of maternal to child transmission? Is it the number of drugs, or is it the fact that you need to have virologic suppression at the time of delivery? So if you go to the new guidelines that look at the use of 2DR, particularly for dolutegravir and 3TC, although this therapy is accepted as non-inferior to standard therapy, the recommendations do not include pregnancy, and that's largely because of the fact that this has not been studied in the face of pregnancy. I suspect it will be perfectly fine as long as the virus is suppressed, but because we don't know, it would probably be cautious for us in the third trimester of pregnancy if a woman did happen to be on 2DR to go up to the third drug until after delivery. Of course, the other consideration for women who are about to get pregnant is what about the teratogenicity? And I think at this and many, many other meetings, we have raised a question related to the Tispano study as to whether or not there can be an excess of neural tube defects with the use of dolutegravir in first trimester of pregnancy. I think we've seen over time that the risk, the absolute risk of that occurring is extremely small, although the relative risk is slightly elevated. The WHO now has stated that if dolutegravir is important for the woman's health, the prevention of maternal-child transmission, and the prevention of transmission to another partner, that is perfectly okay to use the drug in first trimester of pregnancy for her health. And then the last consideration is, what about if a woman is on an injectable drug and becomes pregnant? And we don't obviously have very much data at all on the safety of the injectable drugs postpartum. This is some data that was presented at both CROI and the Women's Conference this year, and it is data from just a small number. It was 3 women who became pregnant on the cabotegravir trials. The women stopped the drug when they were found to be pregnant, but they continued to monitor drug levels throughout the course of their pregnancy. And it was found that these 3 women did have therapeutic drug levels at the time of delivery, and many of them continued to have detectable cabotegravir for 2 to 23 weeks postpartum. So there does continue to be drug in the woman for a prolonged period of time after the drug is discontinued. And I think we simply do not know about the implications of the safety of that in pregnancy at this time. So what are my conclusions for 2DR in women? If we look at all of the clinical trials on the initiation of 2DR and 2DR for switch, efficacy seems to be similar. Again, if we look at toxicity of the 2DR regimens, it seems to be similar to that described in men. I think from the Atlas and FLAIR study, we were able to show that women do accept injectables as being part of their therapy, and for some women, this is a preferred method of administration. I think, however, the caution is that the PK profile of these injectables needs to be considered in the context of pregnancy considerations, given the long PK trail. And again, lastly, the concern is it safe to use 2DR in pregnancy? And my own opinion is I think that it would be fine if a woman is on 2DR and suppressed and becomes pregnant. I think that would be fine. You may want to give some consideration to switching her to standard therapy in the 3rd trimester of pregnancy until we understand the issues related to maternal-child transmission. So I hope that I've been able to share with you today my thoughts around 2DR for women. I thank you.
Thank you very much, Sharon. That was a wonderful talk. I would like, if you have time, to elaborate a little bit on something you touched on, the use of dolutegravir in pregnancy. There was a lot of concern and data emerging. I'd like to take advantage of your expertise on this and hear your personal opinion. Where are we now, and what do you recommend to us?
Yeah, thanks, Jonathan, for the question. And I think me, like everyone else, when the message came out from the Tispano study, I think we all became very concerned. And of course, the last thing we want to do is do harm to a developing fetus. And so, like everyone else, I counseled all of the women in my practice. I, looked at women who were contemplating pregnancy and often made the suggestion for those women to switch to an alternative drug. I think as the activists have spoken and as the data has emerged, I think that the absolute risk of this appears to be declining, although there is still a small relative risk. So everything has to be taken in context. So you need to balance the benefit of that drug for the maternal health versus the risk of maternal-child transmission versus a small risk of a neural tube defect. And there was a study presented at CROI in which women were randomized after first trimester of pregnancy to take a dolutegravir-containing regimen as opposed to a tripla, and there were more women suppressed at the time of delivery on the dolutegravir-containing regimen. So I think that's a very important piece of information. I think rumor has it, we're also going to get more data from the TSAMO study as a late breaker at the IAS conference next week, so I think we'll all be listening to that. But I think at the current time, I have continued to use dolutegravir in women of childbearing potential. I do discuss the potential risks and benefits, but I certainly have many more women that are taking dolutegravir despite their interest in becoming pregnant.
Well, thank you, Sharon. That makes very good sense to us. So I'll step back and allow you to introduce our next speaker.
Great. So we've heard a lot of points around the two drug regimens, some of the concerns that people may have, but obviously the most important thing is taking it back to your office and identifying where it may be used. And so we've asked Mary Montgomery today to bring it all together and to discuss with us a clinical case. Dr. Montgomery is an instructor of medicine at Harvard Medical School. She's a staff physician in the Division of Infectious Disease at the Brigham and Women's Hospital. She's very involved in medical education and therefore an ideal person to present a case with us today, and is also directs many of the clinical skills of our young emerging doctors. So Mary, welcome to the floor.
Thank you so much for the invitation to speak today. I'll be going over a case presentation. I have no conflicts of interest. So here's our case. This is a 55-year-old man with long-standing HIV, diabetes mellitus type 2, and hypertension who comes for follow-up. He's a longtime smoker and unfortunately was just diagnosed with COPD. His PCP would like to start him on corticosteroids, but sent him to you in order to discuss his HIV regimen. He is currently on darunavir and cobicistat with tenofovir alafenamide and emtricitabine, TAF, FDC, as you've seen here abbreviated. In reviewing his prior resistance tests, you note that he has the M184V mutation. When you ask him about this and review his records, you note that he had failed efavirenz-based therapy over 10 years ago. His current labs indicate, though, that he is well suppressed with his viral load at less than 20, and his CD4 count is 560. So now that you have this information, what would you like to do with his ARV regimen? Would you continue him on darunavir cobicistat and TAF FDC due to his M184V mutation? Would you switch him to rilpivirine and TAF FDC, to dolutegravir TAF FDC, to the combo pill of dolutegravir abacavir 3TC, or would you give him dolutegravir, rilpivirine, and TAF FDC? So I want you to think about these options, and we're going to come back to this question after we review some of the data. So first, let's take a little bit of a step back and talk about M184V. So M184V is a great mutation, and I stole this from one of my mentors and colleagues, Paul Sachs, where on his blog, he put up the best treatment for M184V. Excellent question. Let's discuss further. So let's go ahead and do that. So as many of you know, M184V is the most common NRTI mutation that occurs after failing 3TC or emtricitabine. And viruses with M184V are, curiously, actually less fit, even though this infers resistance to lamivudine and emtricitabine. Those drugs actually still work and decrease viral replication, and even the mutation itself makes the virus less fit. So it causes this phenotypic resistance, but patients actually still have a decrease in their viral loads when continued on 3TC and FTC. The other curious part about M184V is that it increases tenofovir susceptibility, and that's both for TDF and for TAF. So then, how do we deal with M184V? Well, initially, the second line trial and the earnest line trial showed us that we can use a boosted PI with recycled nucleosides in patients that are failing first line NNRTI therapy. So that's what everyone initially did, was a boosted PI regimen for those with NNRTI or NRTI resistance. And then the Dawning study came out, which I'm going to go into in more detail, but this was a study that showed us that using dolutegravir-based regimen with recycled nucleosides could also lead to viral suppression in those that were failing a first-line regimen with an NNRTI. And then the 40/30 study and the BRAVE 2020 study were much more recent studies presented at CROI that showed that in patients who were virologically suppressed but had a history of M184V, that switching them to either a dolutegravir or bictegravir regimen maintained virologic suppression even in the face of an M184V. So we're going to talk about the Downing study more, and we'll talk about the 40/30 study. And then dolutegravir, 3-TC, and abacavir is not recommended, as M184V does lead to low-level resistance to abacavir. There were some early studies looking at small numbers of patients who had M184V and were switched, virologically suppressed, and switched to an abacavir-containing regimen and did okay. They did not have virologic rebound, but that was very small patient numbers, and for now, it is not recommended to use abacavir in the setting of an M184V. So here's the Downing study. So the Downing study was published in Lancet in 2019, and this was, as I mentioned, a large study of patients who had failed first-line NNRTI regimens. So they had NRTI resistance and NNRTI resistance, and they were randomized to either dolutegravir plus recycled nucleosides or lopinavir ritonavir and recycled nucleosides. And at baseline, about over 80% of patients in both arms had M184V. They also had multiple other mutations. In the study in general, 88% of the participants in the dolutegravir arm were virologically suppressed at week 48 as compared to 77%. They actually ended this study early, given that dolutegravir was found to be superior to the lopinavir. And when you do the subset analysis of those with the M184V mutation, you can see that 84% of patients in the dolutegravir arm achieved virologic suppression at week 48 as compared to 72%. So this is not our patient, right? These are patients who had an uncontrolled viral load and mutations, but it still did well on dolutegravir. So we can infer in someone who has a history of M184V and is suppressed that switching to a dolutegravir-based regimen would be safe. We also have data, apologize, before I get to that, let me just show you this graph here from the Downing study. And this just shows the proportion of participants who achieve virologic suppression. And you can see at week 48 is in the 80s for those on dolutegravir as compared to the 70s for those on lopinavir ritonavir. So moving on, this was the more recent 40/30 study, which was enrolled patients who are similar to ours. So this is a patient who was virologically suppressed and was switched to either, in this study, either to dolutegravir and FTC-TAF or to bictegravir-TAF-FTC for 48 weeks. And this was a large study really looking at the efficacy of switching to bictegravir-TAF-FTC. But a small subset, and this was an analysis, a small analysis presented at CROI in 2019, showed that 81 patients had M184V, which was about 14% of participants. And this number increased to 24% when using proviral DNA genotyping. So this is when you go back and do a genotype analysis on someone who has a suppressed viral load, and you look at the pro-virus genotype in PBMCs, and what you can see there are kind of archived resistance. And so when they did that analysis, they found that up to almost 25% of patients had an N184V mutation. And 99% of the participants in the overall study maintained suppression, 99% of those with any drug resistance maintained suppression, and 98% of the 81 participants with M184V maintained suppression. So all also kind of reassuring and further data to support that in someone with a prior history of M184V, they can switch to a dolutegravir or bictegravir-based regimen with TAF and FTC. So what would you do with his regimen? So let's go through these again. So we would not continue darunavir, cobicistat, TAF-FDC because it is because of the interaction with steroids. We would not want to use cobicistat or ritonavir, so that's why we're making this switch in the first place. We would not want to use rilpivirine, as rilpivirine as an NNRTI has a lower barrier to resistance compared to integrase inhibitors and protease inhibitors. And given its distant history of virologic failure on an NNRTI-based regimen, we would not feel comfortable switching someone with underlying NRTI or NNRTI resistance to this. We would not want to use dolutegravir bacavir 3TC as M184V leads to low level resistance for abacavir. And then it is unnecessary to use dolutegravir, rilpivirine, and TAF-FDC. We do not need the addition of rilpivirine in this situation, given the data that we presented in the Dawning study, and there's the Brave study, and also in 4030 study. There's sufficient evidence that he will be fine and continue to maintain virologic suppression on dolutegravir and TAF-FDC alone. So that is what was chosen here. So let's continue the case now. So he is 6 years later. He is now a 61-year-old man, continues to have well-controlled HIV. His COPD diagnosis that we know of, diabetes and hypertension, comes for follow-up. But unfortunately, over the last 6 years, he's had notable weight gain, and he's now obese with a BMI of 32. Unfortunately, not surprising given the use of integrase inhibitor and TAF. He has worsening renal insufficiency due to his diabetes and his hypertension, and now his creatinine clearance is 30. He remains on dolutegravir, TAF-FDC, and you let him know that you're going to switch his HIV regimen due to his diminishing kidney function, and he asked whether he could be on 2-drug therapy. He's heard about this in the news. So what would you do? Would you switch him to 2-drug therapy with dolutegravir and 3TC? Would you switch him to 2-drug therapy with dolutegravir, rilpivirine, or would you switch him to dolutegravir, rilpivirine, and 3TC? So we'll come back to this question after we review some of the data. So what about 2-drug therapy in M184V? Well, the bottom line is that we really don't have that much data on this. And let's go through kind of the little bit of data that we do have. So the TANGO study was a large randomized trial that switched patients, randomized patients to either staying on their TAF-based triple therapy or switching to dolutegravir and 3TC. This was a large study and excluded patients who had resistance, but interestingly, in the results section, they did note that 7 patients, again, super small number, had proviral, so again, we talked about proviral testing, M184V, and of those 4 that were in the dual arm, they all maintained virologic suppression. Again, can't really say much about that, such a small number. And then the ART-PRO study, I'll go into a little bit more detail, but this was 21 patients with historical 3TC resistance who were switched to dual therapy. And then there was a retrospective analysis from an Italian database, looked back at patients who had switched to 2-drug therapy and had an M184V, and they showed increased viral blips. So let me go through those 2 studies. So the ART-PRO study was very small. They got 41 patients who were virologically suppressed. Half of them had historical evidence of M184V or K65R, which is a tenofovir mutation, and 20 had no historical resistance. They all underwent proviral DNA testing, and they were actually excluded if they have M184V. So these were very distant results that were not even caught on proviral testing. All of them were switched to dolutegravir and 3TC, and at week 48, all of them remained suppressed, except that 3 of the patients in the historical resistance arm did not. 1 was due to an adverse event, and 2 had protocol violations, so they left the study. Again, very specialized population and a very small study. And then the last one to review here is this retrospective analysis that was done in Italy using the ARCA database, where they looked back at 436 patients who had switched to dual therapy. It was either 3TC and dolutegravir or 3TC and a boosted PI. And there was just a small subset of them, so 87 had the M184V mutation. And they looked at whether there was a difference in the time to virologic failure between those who had the M184V mutation or those who didn't. And they noticed no difference in the time to virological failures, but they did notice increased probability of a virological blip. So that's an isolated reading of a viral load between 51 and 199. And that was increased in those with M184V. So very limited data and a kind of concerning signal of potential increased virologic blips. So lastly, one of the other options was switching to dolutegravir and rilpivirine and avoiding NRTIs in general. And this was studied in the SWORD study, which was a randomized trial, basically having patients who are virologically suppressed. They were continued on their baseline ART or switched to dual therapy with dolutegravir rilpivirine. And at week 48, 89% as compared to 93% had maintained virologic suppression at less than 50 copies. The concerning piece here, though, is that 10 patients had virologic withdrawals through week 100, and of those, 3 had an NRTI resistance mutation. So the barrier to resistance of rilpivirine, as we discussed, is low. And so the concern here, and patients were all excluded if they had any history of dolutegravir or rilpivirine resistance. And so the issue here is that most patients who would develop an M184V mutation would have often failed an NNRTI-based regimen. So even though an NNRTI mutation might not have been seen, it could be there at low levels. So going back to our question here, what would you do? Well, we would not switch to dolutegravir abacavir, again, talking about the risk of abacavir in the setting of M184V. We would not switch to dolutegravir and 3TC, given the extremely limited data. Those patients were largely excluded with M184V, excluded from the trials of switch therapy. It's not recommended in those with underlying resistance or history of failure. Switching to dolutegravir and rilpivirine could be considered, but I would say that it is too risky given his history of failure on an NNRTI regimen in the past. So what I would do in this situation is use rilpivirine, dolutegravir, and 3TC, which would be a robust regimen in someone with renal insufficiency and with M184V. So in summary, we talked about how bictegravir or dolutegravir and TAF-FTC are approved second-line regimen for those patients with NRTI and NNRTI mutations. We talked about the Dawning study, 4030, and the BRAVE 2020. Two-drug therapy is approved in many patient populations, and those are all patients without baseline mutations. So at this moment in time, I would not recommend two-drug therapy in those with underlying mutations and or a history of virological failure. Possibly this will change in the future, but based on the extremely limited data that we do have, I would not recommend two-drug therapy in someone with underlying mutations. So thank you so much for your time and for the invitation.
Thanks very much, Marianne. I think you would all agree that a good educator presents data to support her conclusions. And I think many of us are concerned that there has been a lot of pressure out there from pharma, perhaps, that we should consider these regimens despite the presence of the 184V mutation. But I share your caution that the amount of data to support that decision is quite limited at this time. But Mary, as everyone's gathering, perhaps I could ask the question is, in the bad old days, we always used to maintain 3TC in order to kind of keep that 184V mutation to keep the virus less fit. Do you think that's still relevant in the days of suppressive antiretroviral therapy?
Yeah, I think that's a great point, and I'm sure others here at the conference will have other, insights into this. what's interesting is that it seems to be some of the best data we have for 2-drug therapy actually comes from those that continue 3TC. And is that the medication that it's also paired with, which is largely an integrase inhibitor, or is that some aspect of the 3TC? And so for me, the times where I'm really often continuing 3TC are in situations where patients are suppressed and have underlying renal insufficiency. Oftentimes in those that don't have underlying resistance mutations, I'm sometimes actually using and dropping the 3TC because having to dose adjust it with renal insufficiency is often can be a nuisance whether you actually need to do that or not. And those patients can sometimes be thrilled to be suppressed on a 1-drug regimen of dolutegravir and rilpivirine. So I think to me, there's not that many patients that I am individually kind of continuing 3TC on just for kind of worry. But the times where I'm using it are those often with renal insufficiency. But I think in an area of resistance, I'm dubious to often rock the boat if I don't need to. And usually the switches that I'm trying to avoid are those that drug interactions. So often trying to get off a boosted PI if I can. And then to data that you eloquently presented earlier, I think one of the biggest concerns my patients face is weight gain. And so often I'm stuck with this conundrum of like, can I get them off an integrase inhibitor, or is there any benefit of getting them off TAF? And so that's more often the discussions that I'm having in my clinic than a discussion particularly on 3TC.
Hey, Robert, do you want to weigh in? Maintain 3TC in the face of 184 or no?
Yeah, I think there are 2 reasons for continuing 3TC in that setting. One is, and this goes back to the mid-1990s, when 3TC studies were first being done, it was shown that even in patients who developed resistance, when they were still on 3TC, they had about a half-log reduction in virus load. Now that's not as good as you'd get if you had fully susceptible virus, which is almost a 2-log reduction, but you do still have some activity of 3TC, even in the setting of M184V, and maybe that's simply because the viruses with M184V are less fit, or maybe 3TC has some activity. The other is that M184 increases the activity of tenofovir, and that also gets you perhaps another half-log. So there is an advantage if you need it, but if you had to look at 3TC versus rilpivirine in somebody who was, let's say, had been NNRTI naive, rilpivirine would have the edge. But in the case you gave, the 3TC provides some added security. So if there's no reason not to, I think 3TC does provide added security, even in somebody with a history of M184V because of the decreased fitness, or if you're teaming up with, a tenofovir or a TAF, you increase the activity of that drug.
So a question for all of you to weigh in on. So why do you think we're seeing less resistance to the integrase inhibitors? Is it the barrier to resistance? Is it the potency? Is it the PK? Is it adherence? Is it everything? Marta, I know what you'll say.
Of course. Pharmacology is good in terms of, so they have a very good pharmacological profile from high inhibitory quotient, drugs like dolutegravir and bictegravir, the new generation of unboosted integrase inhibitors, and also they have a favorable PK forgiveness. But I think that the barrier to resistance is actually a multifactorial concept, and I like to put pharmacology into the explanation of barrier to resistance. So the levels and the persistence of the drug. So if people are late with their dose, the concentrations are still good enough, and all the other resistant factors. So I think the barrier to resistance is the right answer, but it does need to be explained and see what all the components of the barrier to resistance are. And dolutegravir is definitely a drug with a high genetic barrier. Also the fact that when people fail in clinical trials, dolutegravir containing regimens failed without resistance. That's quite incredible, because before that we have been seeing it only with boosted protease inhibitors.
Robert, anything to add?
Well, I think we're just very lucky with these two drugs, dolutegravir and bictegravir. I mean, developing resistance on those drugs in somebody who's never had an integrase inhibitor before really remains reportable. The number of cases is so few, and I think that may be because people stopped using dolutegravir monotherapy with no other drugs. But as long as you have an additional drug with some activity, it seems that that is often enough to prevent our resistance from emerging. So I don't know the reason. I just think that these are amazing drugs, and we're lucky that we have them.
But Mary, obviously the patient's important, and is adherence a big factor too?
I would say that it was pretty game-changing when I was able to offer to my high-risk patients who struggled to take their medications and struggled with the side effects of boosted PIs, to be able to switch them to dolutegravir. In my situation, many of them were not suppressed because they just couldn't handle the boosted PIs with GI side effects, diarrhea, and I worried about switching them to any other regimen given their, challenge with adherence. And so I would have many patients, one of whom, was finally able to suppress and was able to actually get a renal transplant after not even being listed on the list for many, many years when he was able to switch to integrase therapy and has been suppressed ever since. So I do think a part of it is, it's not the main reason, but it's an added benefit. Although, of course, now we're dealing with the weight gain, but, right. At the time it was without any complications. Yeah. And
now we have the injectable, so we give choices to patients as well. Mm-hmm. So Marta, there's one last question on the chat. Someone has said, well, what do you do with somebody who's getting older? They're starting to get in some degree of renal insufficiency. They're taking all kinds of other drugs. What about an NRTI sparing regimen to kind of cut out the drug interactions, to cut out the drug adjustments? Would that be a good way to go?
Well, it's a great idea. Our population living with HIV is aging, and we need to think about that. So we talked a lot about drug interactions, both myself, Sharon, talking about women, Mary looking at her case. So they are clearly important in clinical practice. And again, they're more likely to happen when people age and are on polypharmacy and so on. So it's a very good idea to have a simple, maybe dual drug regimen with low potential drug interactions. I think that we need to remember, and I hope you agree with me, that combinations, antiretroviral combinations without reverse transcriptase inhibitors, so either at least an NRTI or an NNRTI, do not seem to do as well. We have the experience of the NIT-301 study that compared dolutegravir and ritonavir to tenofovir and tirzepatide. But if we can replace the NRTI because we worry about the kidney or other toxicities with an NNRTI and then boosted integrase inhibitors that are associated to a low potential for drug interactions, I think that would be very favorable for aging patients.
And I think for whatever reason, we've learned from these two drug regimens that an NRTI seems to be an important component of the therapy. And from some of your discussions, maybe keeping 3TC in that combination is not a bad idea either. So I think in light of the evening, or no matter where you are, we're coming to a close. So I would like to thank all of the speakers from this session for a very interesting and interactive session. For those of you who are in Canada, happy Canada Day tomorrow. And I will pass this back to Dr. Shapiro for closing remarks.
Thank you.
It's time to close the first day of the meeting. I would like to take this opportunity to thank our fantastic faculty for all their talks. I'd like to thank you for submitting your questions in the discussion we had. A thank you to Vive Healthcare for the independent educational grant they provided. I'd like to remind you that you can claim CME credit online, and for those who would like, request a certificate of attendance. All the material will be available at academicmedicaleducation.com. And a reminder that tomorrow we have another great lineup of speakers and 2 more sessions. For those who are interested in contacting Virology Education, you can do so by social media, and you can see here on the slide. And with that, I'd like to say goodbye and look forward to seeing all of you tomorrow. Thank you.